Hi everyone, and thank you for listening. My name is Michelle Sestak. I'm the current PGY2 Oncology Pharmacy resident at Monument Health, and I'm going to talk to you all today about ovarian fertility preservation. Fertility preservation is an important topic in oncology because chemotherapy and radiation therapy can often result in reduced fertility for patients. Because of that, all premenopausal patients should be talked to about the potential impact of chemotherapy on fertility and also asked about what their desire is for potential future pregnancies. Any patients then who do want potential pregnancies in the future should consider fertility preservation options and should talk to a fertility specialist before they start treatment, so that's all sorted before they actually start getting treatment. There are a few different considerations for fertility preservation that we take into account when choosing the specific type of fertility preservation for patients. Really, the main thing that we'll want to consider is patient desire and really what's feasible for specific patients. Other things that are considered are tumor stage and biology, the patient's age, the risk of premature ovarian failure based on the treatment, and then the timing and duration needed for fertility preservation. Listed here are the main options for fertility preservation that are available. I'm going to go through all of these a little bit more in depth, but the options that are available are embryo cryopreservation, cryopreservation of unfertilized oocytes, ovarian transposition, ovarian suppression with LHRH agonists, and lastly, ovarian tissue cryopreservation and transplantation, which is more of an experimental option. The first method, and one of the more preferred methods that I'm going to talk about, is embryo cryopreservation. This method involves removing eggs from the ovaries, fertilizing them to create embryos, and letting them grow for several days and then eventually freezing them. When those frozen embryos are thawed, then the fertilized eggs can become implanted in either a patient or another person so that the patient can have a child. This is a preferred method and recommended by the American Society of Reproductive Medicine guidelines on fertility preservation and reproduction for patients facing gonadotoxic therapies. So if it is feasible for a patient, this probably would be the method we would want them to choose. Some things to note is that it is only available if there is time before treatment to undergo a cycle of stimulation to obtain eggs, and there needs to be a safe method of ovarian stimulation that exists as well. Another thing to note is that it does require use of donor sperm. So if the patient does not want to use donor sperm or there is not time for a cycle of stimulation or safe stimulation method, this may not be the most preferred method for those patients, but overall it is one of the more preferred options. The next method that I'm going to talk about is cryopreservation of unfertilized oocytes. So this could be an option for a patient if they do not want to use donor sperm, as it does not require use of donor sperm. It really should be offered when embryo cryopreservation isn't feasible or desired for patients. And the process of this method involves taking the ovarian follicles and stimulating them, collecting the follicular fluid, and then extracting mature oocytes and eventually freezing those oocytes and storing those. It is also a recommended option by those fertility guidelines and is preferred if the embryo cryopreservation isn't feasible, like I mentioned. Another available option is ovarian transposition. This is a surgery that moves ovaries out of a field of radiation. So the place in therapy for this method is that it can be offered when pelvic irradiation is performed as cancer treatment. Another option, kind of along the lines of this one, is radiation shielding, just to prevent the radiation from getting to the ovaries. But if that's not possible, we can consider this surgery to actually move the ovaries out of the radiation field. This surgery should be performed as close to the time of radiation as possible, as this decreases the chance of failure from the ovaries migrating back into the field of treatment, which is possible if the surgery is done too early. There are some complications of this surgery, such as chronic ovarian pain, infarction of the fallopian tubes, and formation of ovarian cysts that you should also take note of when considering this. We also have medications such as leuprolide, goserelin, and triptorelin that are LHRH agonists that are available options for ovarian suppression as well. These work mechanistically by downregulation of the LHRH receptor, so essentially they block hormones that stimulate ovaries to prevent eggs from maturing, and that's thought to be how they work for ovarian suppression. They do have some toxicities potentially associated with them, such as hot flashes, osteoporosis, and injection site reactions. And to note with these, there is conflicting evidence for fertility preservation. So there are some studies that show that they're pretty good for this, and then there are some studies that don't exactly show that. So because there's conflicting evidence, it maybe can be recommended when proven fertility preservation methods aren't feasible, as well as in the setting of young women with breast cancer. Like I mentioned, there have been some randomized trials that have demonstrated administration of these LHRH agonists before chemotherapy and concurrently with chemotherapy protect against ovarian failure and reduce risk of early menopause, so they are worth considering for some patients that are appropriate. I wanted to include information from one trial that did show benefit with an LHRH agonist. This trial was called the POEMS trial. For the population, it is important to note that they did only include patients with hormone receptor negative breast cancer. They did look at goserelin 3.6 milligrams sub-Q every 4 weeks, starting 1 week before chemotherapy and continuing to within 2 weeks before or after the final chemotherapy dose. And with that goserelin, they found that the ovarian failure rate was 8% in the goserelin group with chemotherapy versus 22% in the chemotherapy alone group. So the ovarian failure rate was quite a bit higher in the chemotherapy alone group in this study. They did also look at pregnancy rates, and they found that pregnancy occurred in more women in the goserelin group compared to the chemo alone group, with a 5-year cumulative incidence of 23.1 versus 12.2%. The last method that I wanted to talk about was ovarian tissue cryopreservation and transplantation. And like I mentioned, this is an experimental procedure, so it does have a low usage rate right now and isn't really one of the more preferred methods at the moment. The process for this involves removing the egg-producing portion of the ovary before treatment and freezing that so that the tissue can later be thawed and transplanted whenever they need to retransplant that. It does require ovarian stimulation or sexual maturity, so because of that, it might be the only method available in children, so that could be a place where we might consider it. But overall, it's not super commonly used right now, and like I mentioned, it's experimental. There was one study that I looked at that showed 52 women were in the study, and they received the procedure and attempted to conceive naturally then, and they ended up having 37 of them being successful, which is about 71% of that population. Thank you all for listening today. Let me know if you have any further questions. My email is msestak@monument.health.